Dear students, in this video, I am going to talk about the use of vasopressors and inotropes in shock, why, when, which one, and how much to use. A little bit going by the history, it is an interesting fact that one physiologist, one engineer by George Oliver, way back some 300 years back, first identified the presence of some substances in the suprarenal gland. And this extract infused it in his son and found that the diameter of the radial artery has increased. Now, based upon his observation, he has met his friend Schaffer in Oxford, who was a physiologist, and they went on to discover the presence of substances in the suprarenal gland, which was later confirmed to be adrenaline and noradrenaline. So we know that the vasopressors and inotropes are a part of the armamentarium that is used right, left, and center in critically ill patients. But while using it, we need to ponder upon the actions that we seek. And although we sometimes tend to overuse this, or we interchangeably use these agents, it is very important to realize their individual importance in the particular endpoints that are of interest. Let us walk along this case to understand the finer aspects of the vasopressors and inotropes. A 65-year-old male post-nephrolithotomy 3 months back presents with fever, pain abdomen, burning micturition, and cloudy urine for 2 days. The patient happens to be a known case of diabetes for 5 years on oral hypoglycemic agents, hypertensive for first 3 years with a combination of sacubitril valsartan, and upon presentation, the patient is febrile with a temperature of 103 degrees Fahrenheit, blood pressure is 100/60, and all other organ systems seem to be normal. The abdomen is tender in the lower part, along with rigidity. The urine shows pus cells more than 10 per high power filled, and the presence of WBC cast along with. The patient is acidotic, and it is a mix of respiratory and metabolic acidosis with metabolic predominating. The lactate is 4.5. The POCUS shows an IVC collapsibility of greater than 50% with a reduced diameter, opacities around the bladder, and enlarged prostate. The echo shows normal LV contractility with no wall motion abnormalities and normal filling pressures. Patient is treated with intravenous fluids or crystalloids at 4 to 6 ml per kg per hour of ringer lactate for 1 hour with gradual escalation alongside antibiotics, analgesics, and other drugs. After giving 2 liters of fluid, the blood pressure is still on the lower side, 90/60, with a heart rate is of 104, which was initially 120. The IVC appears to be normal size and non-collapsible, and yet the patient is not fully resuscitated. Now, in this particular scenario, which is not uncommon, how to decide whether between fluid escalation and vasopressor initiation? Now, the etiology of shock has a major influence on the fluid prescription. We know that the fluid is largely distributed uniformly between the blood and the fluid compartments in the vascular system, in the circulatory system, and the heart. Now, when there are certain types of shock, such as the distributive shock, this is the septic shock, the problem arises, the pathology occurs mainly in the permeability and in the regulation of the tone. So it is also called vasoplegic shock. And because of this permeability, there is a huge shift of the fluid from the intravascular to the extravascular compartment. In hypovolemic shock, there is also loss. And this loss is also both the compartments, that is the intravascular and the extravascular. So the total volume of resuscitation needs to be corrected based upon these losses in these two. On the contrary, in both cardiogenic and obstructive shock, the loss is not primarily from the body, but it is actually more of it is determined by the afterload and determined by the functionality of the right heart. So therefore, in this patients, a reduction of afterload and an improvement in the contractility probably needs to precedence over volume resuscitation. So the etiology of shock needs to be understood in any particular patient. And if there are more than one elements, then the preponderance or prerogative of the particular type of shock needs to be accounted for determining the amount and duration of fluid resuscitation. Now, there are very pinpointed history which can suggest the suspected diagnosis, like if it is primarily related to the airway problems like obstruction, breathing, muffled speech, cyanosis, or breathing problems like tachypnea, rhonchi, lower saturation, hyperresonant sound on percussion, etc., then if we have to assess by doing an echo, and if the echo, the ventricular filling pressure is reduced, it is more of a volume related factor. So in those patients, probably the correction of the volume, a bit an error with an error on the higher side, may be fruitful in reaching the endpoints. In contrast, in patients with a cardiac and extracardiac, that is the obstructive shock, they will have arterial hypotension, volume loss with tachycardia or bradycardia, prolonged capillary refill time, a rise in lactates, alongside with an altered consciousness or restlessness with cold, clammy skin, and cold sweat, flush, and fever. So in this patients, if once we do an echo, it will be variable depending upon the cause in obstructive shock, whereas in cardiogenic, the contractility will be reduced and the ventricular filling pressure will be high, in contrast to the volume related where the ventricular filling pressure is less. So these are the patients where probably correction of the afterload is required and improvement in the contractility is required, and therefore the target should be to improve cardiac output and to increase or augment the SVO2 if we are measuring. Now, this is very important to understand that whenever we resuscitate fluid, the Rose concept dictates us that initially there is a phase of resuscitation in which we have to rescue the patient with an administration of sufficient fluids, not necessarily with 30 ml per kg within 1 hour. It will be variable. So with a continuous assessment, but that's the area where a fluid is must for resuscitation. And this may range from minutes to hours, after which the organs are rescued and there is a phase of optimization where fluid should be administered only according to the patient's need to prevent overload or to avoid receiving a situation where the complications of fluid overload can manifest. So to maintain hemostasis and achieve a neutral balance is the primary target during those which may last from hours to days. The third phase is the phase of organ support, where stabilization with late conservative fluid administration to provide adequate organ support with organ perfusion and achieve a negative balance is the target. And this is the phase of stabilization, which may vary up to days, 2 weeks. And finally, when the organ recovers, there is stabilization with active late goal-directed fluid removal in case of overload, and where we may need to evacuate the extra fluid that has accumulated in the body, and by doing administering diuretics, RRT, etc., in order to resolve this fluid overload and achieve a negative balance, because that puts the patient at the risk of hyperperfusion. So if we realize this, we can very well understand that at any of these phases between optimization, stabilization, and evacuation or de-escalation, there is a role of vasopressors in order to maintain the pressures instead of fluid administration of increasing the preload. Now, we have to continue fluid until when the patient becomes fluid unresponsive or the patient becomes fluid intolerant. Now, to understand this intolerance, we need to understand that what are the manifestations of fluid overload, and if we can identify them by doing some point of care bedside tests, then we can very easily stop further fluid administration and prevent any harm. Now, most of the literature suggests that the vasopressors and or inotropes should be used early, because sooner it is used, probably the beneficial effects accrue to the greater extent, and this reduces the chances of complications. So the Surviving Sepsis campaign recommends applying vasopressors within first hour when fluid administration is not sufficient to achieve the hemodynamic resuscitation goals. The ESICM has also recommended starting vasopressors early, even before completion of fluid resuscitation. And studies have found that early norepinephrine administration corrects hypotension faster and then prevents the prolonged severe hypotension, which often becomes the cause of multi-organ dysfunction. Norepinephrine also exerts a synergistic effect, as it has been found, alongside fluid infusion, and enhances the effectiveness of resuscitation. So even when the fluid boluses are continuing and the fluid targets have not been met, side norepinephrine can be started alongside to achieve these effects. And it has also been seen that this early vasopressors may recruit the microcirculatory vessels. And this is very important because finally the perfusion depends upon the microcirculation, that is the circulation of the blood vessels with less than 150 micrometer in diameter. Because as long as there is hemodynamic coherence, an increase in the cardiac output will produce an increase in the perfusion. But when there is hemodynamic incoherence, particularly in distributive shock, in vasoplegic shock, the further increase in the cardiac output may not produce a corresponding equivalent increase in the tissue perfusion. So in those cases too, early vasopressors helps by recruiting the microcirculatory vessels and improving the microcirculation, and thereby improving the organ perfusion. A simple way to identify patients who need norepinephrine is to look at the diastolic pressure, because a low diastolic pressure is mainly due to depressed vascular tone, especially in the setting of tachycardia where the patient is presents. So if you look into this chart, you can see that certain drugs, phenylephrine, vasopressin, midodrine, they are having vasoconstrictor effect. The norepinephrine also has a positive inotropy effect, but that is much less than high-dose epinephrine, low-dose epinephrine, dopamine, etc. On the contrary, if you see isoprostol, that particularly has a positive inotropic effect, that it improves the contractility and cardiac output without producing any vasoconstriction. So this is also important because the vasoconstriction is necessary in many patients, particularly in those with sepsis, to raise the blood pressure. Because whenever we use certain drugs with vasodilators to reduce the afterload, they tend to cause a precipitous fall in the blood pressure. So this fall in blood pressure can again affect the kidney perfusion, and urine output may fall. So this is very important to understand the dilatation part, the contractility part, and the constriction part as with regard to the particular vasopressor or inotrope. Now you see the effects of all these different drugs, whether they are ionoconstrictors, inodilators, or vasoconstrictors, vary on the target sites. That is, the parameters have their own influence on the cardiac output, on the SVR, on the wedge pressure, mean arterial pressure, and the heart rate. While some, like the dopamine, tends to increase the heart rate significantly so as to make it contraindicated in the presence of tachyarrhythmias. Others like dobutamine and the inodilators like dobutamine produces only a modest increase in the heart rate, and so does vasopressin. So it is very important to understand the effects of these drugs on the particular vasculature so that the effect on the rate, on the heart rate, arterial pressure, wedge pressure, and the systemic vascular resistance can be well identified, known to prevent any catastrophe during administration of such agents. Now, why norepinephrine is the first choice among the vasopressors? This is because norepinephrine primarily increases the blood pressure through its vasoconstrictive properties, and it has little effect on the heart rate. If the heart patient is having tachycardia, we know that the diastolic filling can get affected. The heart fills during the diastole, and so the time is reduced. Next is the norepinephrine is potent alpha 1, alpha 2, but it is less potent beta 1, beta 2 receptor binding and increasing the smooth muscle intracellular calcium concentration and vasoconstriction, along with little bit of positive inotropic activity. So that is the reason why it is the first choice. And it is also important to know that it can increase the cardiac output through several mechanisms, like by increasing the mean filling pressure and redistributing the blood from the increased unstressed volume to the reduced stressed volume, improving the coronary perfusion pressure through an increase in the diastolic pressure, and an improvement in the microcirculation through an increase in the organ perfusion pressures. So this is the reason primarily where norepinephrine is scores over others and is chosen as the primary agent in patients who are requiring support. So early administration of norepinephrine may allow achieving the initial MAP target faster and reducing the risk of fluid overload so that you don't end up giving too much of fluids by the time the patient achieves the targeted blood pressure. It is very important to look into this vast trial, which tried to see in adult patients with septic shock whether the addition of vasopressin infusion compared to norepinephrine infusion alone decreases the mortality at 28 days. Now, this trial did not demonstrate a mortality benefit by adding vasopressin if the mean arterial pressure was adequately maintained with the standard vasopressors. However, the strength of the evidence is not strong enough to conclude it definitely does not have a benefit. And important again point was to see that the trial was underpowered because the observed mortality was considerably less than the expected mortality, and the dose of vasopressin also was low. So considering all this, this trial has to be taken with a pinch of salt to understand where exactly the problem lies. Now, this is another trial, the VANISH randomized clinical trial, which looks into the effects of early vasopressin versus norepinephrine for kidney failure in patients with septic shock. So since they have changed the goal, it is not the mortality, but it is the kidney failure. So again, the outcome calculations and the sample size were all based upon that. But the study found that the early use of vasopressin compared with epinephrine did not improve the number of kidney failure-free days in adults with septic shock. So again, we need to understand this limitations nicely before finally concluding that what will be the applicability of the study in our scenario. There have been pooled results which suggest that addition of norepinephrine to non-putecalamine vasopressors was associated with marginally significant reduction in 28-day mortality. Moreover, they were able to shorten the length of the mechanical ventilation, improve the renal function by improving perfusion, of course, a decrease in the heart rate, an increase in the 6-hour shock reversal success rate. But all this came at the expense of increased risk of hyponatremia and digital ischemia. So once we can control or contain these two things, then probably this is the best possible solutions in hand. So much so that there is an updated norepinephrine equivalent score in intensive care, which is used as a marker of shock severity, and it can be used to comparison of the different agents in different settings, and also the eligibility criteria and outcome in the clinical trials. So as you can see on the chart that this updated norepinephrine equivalence, it considers 1 into the dose of epinephrine followed by 1/100th into dopamine, which again becomes the norepinephrine equivalent, 0.06 times of phenylephrine in mics per kg per minute, which again becomes gives us a norepinephrine equivalent. So this norepinephrine equivalent is frequently used in clinical trials to quantify the total amount of vasopressors, which would otherwise become very wide depending upon the patient's duration of support required and the duration of ICU stay. So considering the potency of each of such agent, which typically includes catecholamines, derivatives, and vasopressins, so that it is a very, very informative score. And intensive care studies use this as an eligibility criteria and also as an outcome measure. Now, whenever we use vasopressors, we need a target because we need to want to continue. And once that target is attained, we need to de-escalate. Based on the previous data, there is a general agreement on minimal MAP target, which should be around 65 millimeter of mercury to initially achieve during resuscitation of septic shock. By contrast, there is no consensus regarding the MAP value above which a further norepinephrine-induced increase in MAP could be harmful. So probably in future, we can have trials which will come out on this lacunae. Then again, this was a systematic review with a meta-analysis on lower versus higher exposure to vasopressor therapy. And this came after the publication of the sepsis cub study, which compared high versus low pressure target in patients with septic shock, with the primary outcome being an all-cause mortality at 28 days and the secondary outcome being all-cause mortality at 90 days. So the pooled analysis of this study showed a higher versus lower blood pressure targets for vasopressor therapy in septic and vasodilatory shock. And in the first study, in patients with vasodilatory hypotension were started on vasopressors, moderate to certainty evidence from 3 RCT showed that a lower vasopressor exposure probably lowers mortality. On the contrary, in the other pooled analysis of higher versus lower blood pressure targets for vasopressor therapy in septic and or vasodilatory shock, they found that the targeting higher blood pressure targets may increase mortality in patients who may have been treated with vasopressors for more than 6 hours. And lower blood pressure targets were not associated with patient-important adverse events in any subgroup, including chronically hypertensive patients. Now, this is one more trial, which was the 65 trial that was a multi-centered RCT in 65 ICUs in the UK, involving almost 2,500 patients, all above 65 years of age, treated with vasopressors for malignant vasodilatory hypotension, that is the septic shock. And the study demonstrated that targeting a MAP of greater than 60 millimeter in the ICU over 65 years of age is safe and potentially beneficial within the context of an RCT. Now, the question comes that after norepinephrine, what? We all know that vasopressin is recommended as the second-line vasopressor. Now, why is this recommendation? A post-hoc analysis of the VAST trial, which I just mentioned 2 slides before, this study found that the vasopressin was more effective in less severe shock, where adding vasopressin to norepinephrine might help reach the initial MAP target faster. So the surviving sepsis campaign guidelines had suggested adding vasopressin to norepinephrine with the intent of raising the MAP to target or to decrease the norepinephrine dosage. In both cases, the patient's outcome improves and the duration of hospital stay is reduced. So this could prevent the deleterious consequences of the excessive adrenergic load or the adrenergic drive that these patients go through. Now, a meta-analysis of studies performed in patients with distributive shock show a lower incidence of AF when compared to vasopressin, when vasopressin was added to to norepinephrine versus norepinephrine alone. And another RCT conducted in cancer patients with septic shock comparing vasopressin to norepinephrine as the first-line vasopressor therapy showed no difference in both cardiac arrhythmia and the mortality. Now, what should be the target blood pressure in chronic hypertensive patients? Now, this is again another question which often comes into us because of during personalized or individualized therapy, because the benefits of renal functions are consistent with the fact that in case of chronic hypertension, the organ flow pressure relationship may slightly shift rightward, so that a MAP value of 65 to 70 millimeter could not be on the autoregulation plateau. So even if it's not on the autoregulation plateau, we can keep it a slightly lower between 60 to 65 and get all the benefits which we would have got otherwise. Now, another important marker is, instead of CVP, is the MAP minus CVP. And the not MAP alone, it is MAP minus CVP is associated with an increased risk of acute kidney injury. A cutoff value of 60 millimeter mercury for the MAP CVP difference found suggests that in case of high CVP, the target should be more than 65 millimeter of mercury. In case of doubt or uncertainty, a norepinephrine challenge can work out the best perfusion pressure to recover or to recruit the microvessels and restore the microcirculation. Now, this is another very interesting study which a personalized blood pressure targets in shock. What if your blood pressure is low? So this was discussed in the American Journal of Respiratory Critical Care 2020. One of the issues where they commented that patients with low premorbid blood pressure receiving higher doses of norepinephrine for longer have a longer ICU stays and a higher mortality, but have neither a greater need for RRT nor more organ dysfunctions. So for now, it is recommended that clinicians should personalize their BP target on the basis of premorbid blood pressure. If it is low, consider lower MAP targets than the commonly recommended 65 millimeter of mercury, which should be put aside in such patients. And conversely, if there is premorbid hypertension, then we have to use a higher target of around 80 to 85. Now, what is the role of individualized MAP targets? An individualized MAP target strategy during vasopressor therapy in the ICU was feasible and appeared to be efficacious in one study in the Journal of Critical Care in 2022. Although increasing arterial blood pressure improved sublingual microcirculation parameters, no concomitant improvement in systemic tissue perfusion indicators was found. So this is also again an important finding which came in 2015 in critical care. And the REACT shock study, that is the individualized based blood pressure targets versus standard care among critically ill patients with shock. So this trial will come next year. It is underway, and this pivotal trial will provide useful evidence to fulfill a crucial knowledge gap regarding common and fundamental intervention in critical care. So is there any maximally tolerable dose? High doses of norepinephrine may compromise the host immune system and promote bacterial growth, and it may also induce myocardial injury and oxidative stress. Now, high mortality rates of 90% and 80% were reported in patients when the dose of norepinephrine is more than 1 mg per kg per minute. Another retrospective study showed a 40% 28-day survival rate in septic shock patients who received more than 1 mg per kg per minute of norepinephrine for more than 1 hour, and the incidence of serious digital or limb necrosis was about 1.2% in the survivors. So there is a good consensus among experts to start a second vasopressor in case of refractory hypertension to prevent the effects of excessive norepinephrine load, which is called the strategy of decatecholamine. So what is the current role of inotropes? Inotropes are the agents which improve the cardiac output. For inotrope agents, when norepinephrine fails to restore perfusion, dobutamine represents the first-line agent. Levosimendan is another agent, which is a calcium sensitizer agent, which improves acute hemodynamics, albeit with uncertain effects on the mortality. But the current information regarding comparative effective outcomes is nonetheless sparse, and their use should be limited as a temporary bridge to recovery. Now, what is the role of new vasopressors in shock? So we had few trials. One was the Athos 3 trial. 3 means 1, 2, 3. 3 times it has been conducted. They showed that angiotensin 2, in comparison to placebo, effectively increased the blood pressure in patients with vasodilatory shock that did not respond to high doses of conventional vasopressors. However, the ATHOS trial was not designed to detect a survival benefit from angiotensin II, and concerns exist on its safety profile. A large RCT by Liu et al. Compared terlipressin to norepinephrine and showed no difference in mortality, etc. And another study was the Sepsis Act study, which was performed in patients with septic shock receiving norepinephrine. Administration of celepressine was used, but in comparison to placebo, did not increase the vasopressor-free days or ventilator-free days, and therefore it did not really pick up in clinical practice. So coming to the final take home is that the angiotensin II might be an alternative in patients with refractory shock. However, safety issues still need to be clarified for the future. Now, if a patient is on multiple inotropes and vasopressors, on which should be discontinued first once the patient achieves a reasonably good blood pressure? So a large retrospective study evaluated the noradrenaline first strategy and the vasopressin first strategy in patients with shock. This study included more than 2,000 patients' data, and nearly half of them had septic shock. So the vasopressin first strategy was associated with higher incidence of hypotension, longer time for shock resolution, and also higher hospital and a 28-day mortality. The other study, which is a single small center, small RCT, which compared noradrenaline first versus vasopressin first tapering strategies, the study was prematurely stopped after recruiting 85 patients because the incidence of hypotension after 1 hour of stopping the vasopressin was nearly 3 times higher with noradrenaline first than in comparison with vasopressin first strategy. So although controversial, from a pharmacological point of view, it may be prudent to taper vasopressin in the first as it has an hour only, as it has a longer T-half, and after that, one can consider tapering norepinephrine. Now, another important aspect is the use of the role of vasopressors for cardiogenic shock. And a recent RCT and meta-analysis on the data suggested that norepinephrine may be preferred over epinephrine in patients with cardiogenic shock. For inotrope agents, when norepinephrine fails to restore perfusion, dobutamine considered the first-line agent. Dopamine and dobutamine are also the drugs of choice to improve cardiac contractility, with dopamine the preferred agent in patients with hypotension. So there have been many RCTs on the vasoactive medications in cardiogenic shock. The important ones are listed here, the capital Doremi, and followed by the SOAP, the CAT, etc. And we see that on the mortality, there is no difference in any of the studies, but definitely in terms of adverse effects, there are a lot of side effects which can occur, and therefore one need to choose the particular agent very carefully and also follow up, take due diligence for follow-up so that any anomalies can be detected. So in septic shock, if after initiation of vasopressors, there can be, with the vasopressor infusion can be continued through the peripheral venous catheter for some time. And the norepinephrine doses that are not rapidly escalating, that is less than 15 mics per minute or less than 0.3 mics per kg per minute. So now initiation of vasopressors is followed by worsening of septic shock. Now, if in this patients have to be prepared to start the second vasopressor, typically vasopressin, as a dose of norepinephrine is approaching 15 mics per minute or 0.3 mics per kg per minute. So we need to start. And if the shock is still refractory to multiple high-dose vasopressors, we have to correct the acidosis. We have to consider methylene blue. We have to understand readdress the additional diagnostic and troubleshooting evaluation, and also readdress patient goals in the light of worsening prognosis. So all this are road to the proper justifiable use of these drugs. So my final take-home message is that norepinephrine is the first vasopressor in shock, and epinephrine and vasopressin remain the second-line therapy in cases of refractory shock. Now, early norepinephrine administration is recommended in order to achieve the initial MAP goal of 65 millimeter mercury faster and to decrease the risk of fluid overload. The diastolic blood pressure should be used to identify patients who need norepinephrine urgently. The optimal MAP target should be individualized as it depends on several factors like history of chronic hypertension, the values of CVP, and the intra-abdominal pressure. In cases of refractory hypertension, increasing norepinephrine at higher doses, which means more than 1 mics per kg per minute, it might be an option, but there are currently other options also. So the consensus is in favor of adding other vasopressors. So thank you very much. In case of any question, you can leave a note and I will try to respond. Thank you.